Doing. I am Taravat Sadr, the former staff of Children's Medical Center. It's very nice to be here with you. And today we're going to talk about meningitis, which I know that you had it in your Persian class. Am I right? You can chat if you're not comfortable with speaking. Do you have it? Oh, so not yet. Okay, this is so your first time that you have a class about meningitis. Okay, as you know, meningitis means the inflammation of leptomeningeal membrane. And we will talk in detail about meningitis, and if we get chance or we have time, we can talk about encephalitis as well. But because meningitis is more important for you, I'm gonna focus on meningitis.
नहीं, ये meningitis की class दे रही है, मुझे मैं भी दे दूँ.
So you had it.
कहाँ?
Okay, so I didn't find that if you have this class or not in Persian. Nothing?
We are in different wards, so some of us.
Some of you had it.
Some are in cardiology, some are in different wards, so some might have it. So
okay,
we're just different.
I got it. Okay, I got it. Okay, Zainab, I got it. And before we start, if you have any question, please ask. And during our session, do not hesitate. If you have any question or any comment, do not hesitate to interrupt me, okay? Any question? Sure. I want to share your textbook here. First of all, meningitis, as you all know, is infection of leptomeningeal membrane. We have two main causes of meningitis. One of them is bacterial, the other one is viral. Before, historically, we called aseptic meningitis when we didn't get positive CSF culture. Okay, so whenever we have negative culture, we call it aseptic meningitis, no matter if it's viral, if it's caused by other diseases, if it's caused by chemical exposure. All of them are called aseptic meningitis. It's like more historical term, okay? You should know something by heart, and I made them as a note for you, which we will check it first, and if you agree, we can get back to your textbook later on. This is all that you should know by heart, okay? There are, when a child comes to your office, with these three symptoms, it means that you should think about headache, you should think about meningitis. And what are the three symptoms? They are headache, fever, and vomiting. Unfortunately, in your textbook, there are many other symptoms that most of them are not related to meningitis. But all examiners, all doctors know that the three main symptoms are headache, fever, and vomiting. For sure, we are talking about older children. In infancy, an infant might come with poor fitting, with drowsiness, with irritability. All are signs of a serious condition, not just meningitis. But in older children, in the presence of these three main symptoms, you might think that probably this patient has meningitis. When you have this suspicion, what would you do for your next step? You're gonna do a physical examination. For sure, you will take vital sign, and there are some physical examinations that can help you to go through meningitis diagnosis. One of them is neck stiffness. Neck stiffness
Prof,
means.
I have a question. In kids, how can we determine that this kid is suffering from headache? Like, how can we really see that there's headache going
That's
on
a
in
very
the head?
good question. Who's asking? I couldn't see the. Can you tell us your name?
My name is Rangarema Kuku.
Oh, Ranga. Okay. The only name that I knew from before. In older children, for sure, they can tell you that they have headache. But sometimes in younger children, they might have some, they might show you that they have problem here. They show you where they have problems. But you're totally right. When they are younger, they can't tell you. So because of this, we can think about other problems like vomiting, like fever, and as I told you, like drowsiness, irritability, like seizure, like coma, even coma, they might come with coma. And we will get back here with headache, Ranga, in our differential diagnosis. Just remind me, okay?
Okay.
And about neck stiffness. When we say neck stiffness, what does it mean? It means that whenever you move your patient's head, it's not relaxed. It's difficult to move. And when you bend the head, when you bend it to lateral side, when you bend it forward, the patient is uncomfortable. Who can tell me what is kerning and what is Brudzinski? Because some of you, or all of you, have done semiology. Kerning and Brudzinski. If you give me a hint, is fine. Don't bother you to give me the exact description. No one, okay. We have two, let me see, there is, with the patient supine flexion of the neck elicits involuntary flexion of the hips or knees. That's fine, exactly. One patient, in both of them, you should put patient in supine position. When you flex the patient's head, patient's knee and hip comes to flexion position, when you, and vice versa, when you put the patient in supine position and flex his hip and knee, and then relax them or then extend them, the patient's head comes to flexion. They are Kerning and Brudzinski's test. And as they comes positive, it means that you probably have inflammation in leptomeningeal membrane because it can't tolerate these movements. Okay. And what are the three organisms? Does someone have any question? Okay. The three organisms that cause a meningitis, you should memorize them. You should know them by heart. First one is Streptococcus pneumonia. Second one is H. influenza. And the third one is Neisseria meningitis. For sure, in infancy, we have different organisms, but you might know them because they are repeatedly cause infection in neonate and infants. GBS or group B Streptococcus, E. coli, and Listeria. Listeria is not a very common cause, but because when we have Listeria, we have it in infancy and in geriatric population, both sides of the age. We should think about Listeria in infancy, and we should cover it. Why did I tell that? You should know them by heart, you should memorize them. Because later on treatment part, you would see that we need them to think about our best treatment, our best antibiotic. Okay. Do you know what kind of bacteria is a Streptococcus pneumonia regarding gram positivity? Is a Streptococcus gram negative or gram positive? Let me see the chat. Gram positive. Thank you, Nyasha. Did I pronounce it right? Thank you. And what about H. influenza? Please do not get confused with influenza virus. H. influenza is a bacteria and is very active in children. You'll see this bacteria in different parts in pediatrics. So be familiar with it. H. influenza is a gram negative, and Neisseria meningitis is also gram negative. So we have a combination of gram positive and gram negatives. Okay. After we thought about meningitis, we should start treatment as soon as possible. And when I say as soon as possible, I mean if you have any tests to do, as much as you have, you should follow them. But if you don't have, you should not postpone treatment to get CSF. It's dangerous, and you'll cause your patient in complications that might not resolve later. What kind of test do we need? For sure, we will do CBCD. And what are we looking in CBC? We are looking for leukocytosis, and most commonly in meningitis, in bacterial meningitis, we see shifting to left. It means that, yes, we will see CSF later. On CBC, we will see shifting to left. It means that we might see PMNs are dominant. ESR and CRP are high. And we need blood culture as well. Why do we need blood culture? Because sometimes blood cultures comes positive sooner than CSF. Sometimes you might not have CSF at your hand, and blood culture helps you. And we need blood sugar. It helps us to compare blood sugar with CSF sugar later. And our gold standard to diagnose meningitis is CSF. We take CSF during a procedure called LP lumbar puncture, and we will get several drops, and then we will provide with smear and culture. And nowadays, PCR of the sample will help us a lot. There is a very long and detailed table in Nelson Essential, which you might get confused while reading this. I don't want you to get confused, so I made it summarized here. You see that in bacterial meningitis, the cell, this is about CSF, okay, LP CSF. The dominant cell are PMNs. And we have a very, very low glucose level in CSF. Protein of the CSF is high, and pressure of CSF is high. In viral meningitis, lymphocytes are dominated, glucose is normal, protein is high, and pressure is normal. We will talk about TB, although it's rare nowadays, but you should know it most commonly because examiners love comparing these three. In TB, you have lymph dominant, glucose is the lowest, protein is normal, and pressure is high. Which one of you have seen LP procedure, especially when they measure pressure? No one? Oh, TB is still a problem in Pakistan. Thank you. It's still a problem in Iran as well, but thanks for the BCG vaccination, it's diminished. You know that BCG is not helpful in adulthood pulmonary involvement. It's still high in all around the world, especially here in Middle East. But regarding meningitis, it helped a lot. So we have less meningitis after vaccination era. Okay, let's see. Thank you. Thanks for vaccination. You'll see here in meningitis that how vaccination helped people. Let me show you a video. It's about.
Most people make a mistake on the puncture.
Okay.
following the skin increases.
Can you see the video? Oh, please don't chat.
Yes.
I can, okay, thank you. It shows how pressure in lumbar puncture is measured.
Skin increase is actually too low. What you've got to do to make sure you felt the spine is processed. Elsewhere. Spine is processing, that's your L4 space. You actually put your finger per side of the L4 space and imagine parallel lines. That gives you a visual guide.
But the volume is low.
The volume is not very good, actually.
Raise your small gland and use your second needle through your gland to get your trajectory. Insert.
As you see, we find the posterior iliac spine, both sides, and 2 to 3 centimeters above it, we insert the needle. Okay, this is normal lumbar puncture, but I want you to consider the latter part, which shows how they measure the pressure.
It's a bit more aesthetic, making sure you're not in any blood vessels. Once you've done that, because the skin's insensitized, you can then take your spinal needle through your leg and insert it. And going at a slight angle. Okay, it's about 45 degree angle. Remembering that if you can get that needle in at that angle, that trajectory, without hitting bone, get the needle up to about halfway, 3/4 of the way in, you should be looking to get CSF out. If you do hit bone, you just got to adjust your trajectory slightly and try again. If you're unsuccessful like this, then you go to the small needle. Try and go through. As long as you don't come into contact with bone, atraumatic needles often find their own way, whereas a traumatic needles often lodge in bone. Eventually, you should get CSF. I think we're getting CSF coming. Once you've had a few drops of CSF come out, just put the stylet back in and get your manometer ready. The main thing with the manometer is to make sure you loosen it before you attach it. It can be very stiff. That is an off tab. So you want that off out to the outside world so that CSF will enter this entry here and rise up through the manometer. You also want to have your CSF bottle ready to go, although usually your assistant will do that for you. Once you have your CSF ready, needles out, attach the manometer, wait for pressure to rise. You may have to wait anything up to a minute for pressure to rise for lumbar puncture. Normal pressure is between 6 and 20 centimeters. One study said that 95% would lie between 8 and 21. In obese subjects, the normal pressure can be up to 25, according to a study from the States. But anything over 6 is almost certainly normal. Anything below 20,
Okay, you see that there is a manometer that it attached to the needle, and the liquid comes up to whatever. We don't have, you might not seen it in, you might not seen it in like Children's Medical Center. But what do? We use a tube for a tube that we use it for Ivoline, and we measure it, like we put measurement on it, and then we attach it to the needle. So as the CSF comes up, we can measure the pressure, and we call it by centimeter. For example, if it comes to 4 centimeter, it's 4 centimeter of water pressure. The pressure is measured like this. And as you saw here, okay. The pressure is high on bacterial meningitis and in TB. And viral, it's normal. Is it necessary to measure this item? No, it's not necessary. So most of the time, we measure just like these 3, and we send another sample for culture and sometimes another one for PCR. Okay. Till now, any question? Okay, let's continue to treatment. Assume that you've seen a patient, a 5-year-old girl comes to your clinic with fever, vomiting, drowsiness, and on physical examination, you detected fever, tachycardia, neck stiffness, and Kernighan-Brugsen's becomes positive. What would you do next? You think about meningitis then, okay? And you would go to check CBC, ESR, CRP, blood culture. Before you get CSF, you should be sure that there is no danger for patient. How should we know that? There are some symptoms that like alarming sign. For example, the patient has anisocoria. It means that the pupil size are not similar. Or sometimes the patient is unstable from the cardiopulmonary point of view. So you won't forego drawing CSF from that patient. That patient needs ICU. Whenever you think that your patient needs ICU, it means that you think the patient is unstable. So you won't get CSF from that patient. The other contraindication for LP is when you have a problem on the skin of that part of the body. For example, there is a big hemangioma there, or there is skin infection at the site of LP. You won't forget. And the other one is when your platelet count is not normal. Don't think about the number of platelet because it's controversial, and besides, there is not mentioned in Nelson Essential. When platelet count is low, you won't do LP. Okay. Before you do LP, if you have all the facilities, okay, you'll perform a fundoscopy to see if there is any problem there or not. What are you looking at fundoscopy? that is papilledema. You're looking for papilledema, although it's very rare to find it, but it's important because when there is a papilledema, it means that the CSF pressure is high, and as you go for LP, the patient will end up to death. We will talk about it later in detail. So that 5-year-old patient has signs and symptoms of meningitis, and you send tests, blood tests, and you've done LP. What would you do for the next step? Are you going to wait for the result, or you're gonna start treatment? No, nothing should delay your, should cause you to delay the treatment. You should start antibiotic therapy as soon as you think that the patient probably has meningitis. As much as you can do the test, it's better. So, for example, in Children's Medical Center, we have all things. So you might send the test, you might perform LP and start treatment. Sometimes you are in a location that you can't perform LP. That means you should start empiric antibiotic therapy and send your patient to another center. What would be the empiric treatment then? Do you remember that I emphasize on Streptococcus pneumonia, H. influenza, and Neisseria meningitis? Our treatment, our empiric treatment, should cover all of them because we don't know what would be expected. One of the best treatments that cover all of them is third-generation cephalosporins, which means ceftriaxone, cefotaxime. When I was at your level, that was the only empiric treatment that we consider for our meningitis patients. But nowadays, because we have a very resistant organism, which is a Streptococcus pneumonia, which now is resistant to cephalosporin, third-generation cephalosporins, we should consider adding another antibiotic, which is that's very good, Nyasha. Vancomycin. Vancomycin should be added to third-generation cephalosporin as empiric therapy. Don't forget it, as empiric therapy. So if I want to add here, I would say cefotaxime plus Vanco. This is your empiric therapy. As soon as you have your blood culture, then you justify your treatment. For example, it comes positive with Neisseria, then you don't need vancomycin. You discontinue vancomycin and continue your treatment to the end. If it comes positive with H. influenza, you don't need vancomycin. You discontinue vancomycin and continue till the end. If it comes positive with Streptococcus pneumonia, you should see the susceptibility test done. If it was susceptible to third generation okay, you discontinue Vanco and go with cefotaxime or ceftriaxone alone. But if it comes positive, if you or you didn't have any susceptibility test, you continue both of them. So the logic behind adding Vanco is resistant Streptococcus pneumonia strains. What about neonates? Neonates symptoms are really vague. What's the dosage? Oh, who wants dosage? Dosage is 100 is 1 to 2 gram per kg, 2 gram per kg of cefotaxime, 1 gram per kg for ceftriaxone, and for vancomycin, it's 20 milligram per kg. You are not needed to memorize them. Later at your clinic, you might need it. Then you'll check it at your books. But as stagers or inters, you won't need it. And nobody asks you about dosage. Neonates are more susceptible to gram-negatives or GBS. I wrote infancy here, but so I added Listeria, as I told you. But in neonatal period, you have GBS and E. coli most commonly. And like other sepsis disease in neonatal period, you should have ampicillin, cefotaxime plus a gram-negative coverage, for example, gentamicin and ampicillin. Or you can add vancomycin instead of ampicillin. So in neonatal period, it's like all kinds of sepsis. We will see the table at the Nelson Essential later. In 2 months of age, it's like cefotaxime and Vanco plus ampicillin for covering the Listeria. Listeria is a bacteria that best responds to ampicillin. So whenever you see ampicillin is added to this regime, it means that the physician is thinking about Listeria. Okay, and you remember that these 3 bacteria that I told you should know them very well. Another application of knowing them is duration of treatment. When should I continue my treatment? It depends on the bacterial type. For meningococcal, it is 5 to 7 days. For H. influenza, it's 7 to 10 days. For Streptococcus pneumonia, it's 10 to 14 days. For gram-negatives, gram-negative bacilli, it means E. coli. It should be 21 days. Meningococcal comes with the fulminant feature. You can see that your patient is almost dying, unfortunately. Petechia, purpura, fever, sometimes coma, they come with a fulminant feature. It's very lethal, but its treatment is really short term. So you can see that after 5 days, you might say my patient has finished the treatment. H. influenza is in between. Streptococcus pneumonia, although it's not coming with that fulminant feature, But unfortunately, the complications are much more than others. So we should take this Streptococcus pneumonia into consideration more than others, because meningococcal, when in meningococcal meningitis patient comes to hospital, it is alarming that I am meningococcal. But the Streptococcus pneumonia is more vague. Okay, what about the specific treatment? I told you, I've already talked about it. As soon as you get your culture ready, you can justify your treatment. And a specific treatment for Streptococcus pneumonia depends on the susceptibility. If it was susceptible to third generation cephalosporins, it means that you need to continue with that one. If you didn't have susceptibility test or it comes resistant to cephalosporin, you'll continue with vancomycin. For H. influenza and Neisseria meningitis, specific treatment is third generation cephalosporins. Okay, now I'm gonna stop this one and I'm gonna share the Essential Nelson to have a better overview of what your book telling. At the beginning, it started with aseptic meningitis. We talked about it. I told you about these three, and it is told that thanks for vaccination in the United States, they have less cases of Streptococcus pneumonia and with H. influenza. Because vaccination of the third one, the Neisseria, is done at the older age, so still in children, they might see Neisseria. Partially treated meningitis. What is this? Assume that 5-year-old child comes to a clinic and the doctor doesn't distinguish that this is meningitis. The diagnosis is not right. For example, he or she might think it's sinusitis and start another antibiotic like amoxicillin. Then amoxicillin works somehow, but not completely. So some of the symptoms might resolve, some might not resolve. And the patient still is uncomfortable and you see the patient. You might think, oh, it might be a meningitis that was missed. You'll do your test, your physical examination. Some of them might still be positive, some of them might not. And even on LP, you might get some part of LP, like, for example, still protein is high, but glucose is normal, or unfortunately, the culture is negative. This is called partially treated meningitis. Somehow, specialists can distinguish it from other type of meningitis, but generally speaking, it is hard to diagnose partially treated meningitis. But you should know that at the beginning, the culture will be negative. And the final thing is protein. Okay, you know that we have myriad of viruses that can cause meningitis. You're not needed to like memorize all of them. Just go forward. On epidemiology, the thing that you should know is that crowding poses children to, poses everyone, actually, not children. to meningitis. And where do we have crowding? In dormitories, in daycare centers, and yeah. This highlight is something that examiners love. A CSF leak means fistula resulting from congenital anomaly or following a basilar skull fracture increases the risk of meningitis, especially that caused by a Streptococcus pneumonia. You know what? When you have basilar skull fracture, what does it mean? It means that the brain space has entered two sinuses, and sinuses may be infected with Streptococcus pneumonia. And it's enough that you have a meningitis with the Streptococcus pneumonia. But when you have penetrating head trauma, means that skin is interrupted and something entered to skull. Then you'll have a meningitis with Staphylococcus aureus. Don't get confused with both of them. I know that we should find it somewhere, but I forget to highlight it. So penetrating the skull injury cause meningitis with Staphylococcus aureus, but basilar skull fracture pose the patient to Streptococcus pneumonia meningitis. Okay. If they ask you what are the most common cause of viral meningitis, it's here, enteroviruses. Enteroviruses and paroicoviruses, most commonly enteroviruses, cause meningitis most commonly. And okay, this is a table that I don't like because it is called about clinical manifestations. See what they include. Apnea. Apnea is not a good sample of meningitis symptom. We told that in infancy, we might have apnea, we might have irritable infant, we might have fever without a source. All of them might show you a serious problem, including meningitis in infants. But they are not a good symptom, good sample of symptom for meningitis. But these are good. Stiff or painful neck, headache, hearing loss. No, it's not a good sample. Hearing loss is a complication of meningitis. So you won't see patient comes with hearing loss and you ended up to the diagnosis of meningitis. It's a complication of meningitis and a very common complication of it. And you see that there is nothing about vomiting, which is a common symptom in meningitis. Okay, let's see what's here. Kerning and Brudzinski sign of meningeal irritation are often positive in children older than 12 months. It means that in younger children, you can't rely on Kerning, Brudzinski, and even neck stiffness. So we might go forward to LP sooner than older, sooner in young children than older children, okay? And there is a phrase here, papilledema is uncommon unless there is occlusion of the venous sinuses, subdural empyema, or brain abscess. although it's rare, it's uncommon, but we do fundoscopy looking for papilledema. If there is anything regarding papilledema, we won't do LP. And this is the table that I summarized it for you. There are too much overlaps here, so you can't really distinguish which one belongs to that one. There is something that I like to remind you. I know that most of you might know this. In tuberculosis meningitis, it is said that acid-fast organisms may be seen on a smear. Yes, when you do LP, you perform it on smear, you might get acid-fast organism. Organisms can be recovered in culture or by PCR. Okay, it's true. But there are other tests that might help us. One of them is adenosine deaminase or gamma interferon level, can be used to aid in the diagnosis. Adenosine deaminase or ADA and gamma interferon levels are useful tests for TB in anywhere in the body. So in pleural effusion, because of tuberculosis, you might get help from these tests. It's not specific to meningitis, but you should know them. Okay, differential diagnosis, Ranga. Many disorders other than meningitis and encephalitis may show signs of meningeal irritation and increased intracranial pressure, including trauma, hemorrhage, rheumatic diseases, and malignancies. Seizures can be associated with central nervous system infection or can be the sequel of brain edema, cerebral infarction, or hemorrhage or vasculitis. You see that there is a wide range of disease or conditions that has been mentioned as differential diagnosis. But I want to tell you two differential diagnoses that every pediatrician think about them whenever think about meningitis, and it's not mentioned here. Those two are, one of them is sinusitis, and the other one is parapharyngeal abscess. What do we have in sinusitis? Let me stop sharing here. The patient might come with fever, and sinusitis might come with fever. The other one is fullness in the head, but a child can distinguish this from headache. These parts are, they might feel here fullness, okay? Older than 7 years old, that the frontal sinus is formed, they might feel headache or feel fullness here. Okay, so fever, headache, or uncomfortable sign of head. And the other one is vomiting. Why do they have vomiting? Because of PND. Because of PND, they might feel something uncomfortable on throat, which ends up to vomiting. So the symptoms are completed, and you might think about meningitis, but the patient has sinusitis. How can you distinguish it? One of the best tests here, physical examination, is helping by helping the tongue stick, the Opslang. By Opslang, you can see PND most of the time. And the patient's Kerning and Brudzinski and negativeness most of the time is negative in sinusitis. But sinusitis is a good example of differential diagnosis for meningitis. The other one is parapharyngeal abscess. What do they have? For example, there is an abscess here in between the muscles here and neck. What do they come with? They come with fever, for sure, and neck pain. They might not come with vomiting or headache, but these neck pain and fever are enough that you think about meningitis. And sometimes the neck stiffness comes positive because the patient is uncomfortable to move his head. So you should think about them, but in parapharyngeal abscess, they might prefer some positions rather than others, and they help you. Okay, let's share again. Treatment. We talked about treatment in detail, but I want you to have an overview of what your book says. Oh, we forgot about adjunct therapy. Adjunctive therapy means that starting dexamethasone as a part of our treatment. Dexamethasone is thought to facilitate the entrance of antibiotic through blood-brain barrier. So we use it sometimes when we think about H. influenza meningitis. Okay, it diminished the incidence of hearing loss of H. influenza, so we can think about dexamethasone when we want to start antibiotic therapy. It is told that you should start these at the beginning of treatment. So how can I think this is H. influenza meningitis at the beginning? Nothing can help you regarding symptoms or your physical examination test, but sometimes, do you remember that I told you sometimes the blood culture comes positive before your LP getting ready? It's that way. You have blood culture positive with H. influenza. You have not started your treatment yet. So as soon as you want to start antibiotic, you start dexamethasone as well. And this table is worth looking. Newborn, recommended treatment is cefotaxime plus ampicillin with or without gentamicin. Do you remember that we talked about them? You remember that I told you always that third generation cephalosporin, and I didn't mention cefotaxime or ceftriaxone. They are about 90% similar, but there is a little difference between them regarding age of application. Ceftriaxone in less than 3 months old might cause liver sludge. So we avoid using ceftriaxone in younger patients. But we have a good substitution here, which is cefotaxime. You see that they, in here, infant and toddlers, it is mentioned both of them together, plus vancomycin, and children and adolescents, ceftriaxone or cefotaxime plus vancomycin. Cefotaxime is preferred over ceftriaxone here because in younger age, ceftriaxone might cause liver slot. Alternative treatments is in newborn is ampicillin plus gentamicin, which is not used like everywhere. It is called to be rather historical. Or when you have susceptibility test of your CSF. But cefepime plus vancomycin is good option. Okay. Now just take a look at the complications. You see that hearing loss is bold here. Hearing loss is a complication of meningitis. It's not a symptom of meningitis. One of the complications that you might have in your meningitis patient is SIADH, inappropriate secretion of ADH, which mostly managed you in ICU if you've been in pediatrics ICU. It's a very disgusting. And I'll not go through them, but you might like to know that SIDH is managed just by decreasing the amount of liquid that you order for your patient. This is the only treatment for SIDH. What about CNS imaging? CNS imaging means CT scan. Should be considered in children who demonstrate focal neurological signs or symptoms for persistently positive CSF culture. When you have focal neurological sign, means that you have anisocoria, you have a seizure that is that shows itself with focal sign. For example, the patient's right hand is shaking during seizure, but all other part of his body is not shaking. It means that we have focal neurological sign. Okay, in this patient, before any other procedures, we do CT scan, we perform CT scan. But the third one, persistently positive CNS culture, is when you have your meningitis diagnosed, but you're waiting for CNS to be negative, but it doesn't come negative after, for example, 2 to 3 days. It means that there might be an abscess there. There might be a local infection there. So you need to do CT scan to find. CT with contrast or magnetic resonance imaging is used to detect subdural effusion with Streptococcus pneumonia and H. influenza meningitis or brain abscess associated with gram-negative organisms. What does it mean? You might see that we do CT scan, but most of CT scans are without contrast. Sometimes we do need CT with contrast. When we perform CT with contrast, it means that we're looking for an abscess. So everywhere in pediatric ward, you see that there are requesting CT with contrast. You might think that you're looking for an abscess or effusion. Subdural effusion is one of the complications of meningitis, and it has not resolving the symptoms. The child still is uncomfortable. You still have fever. There is still positive neck stiffness. What might be the cause? Subdural effusion. It means that liquid accumulates somewhere in subdural area. It is almost always it's gone by itself. Sometimes it needs a neurosurgery procedure, but to find it, we need CT with contrast. Okay, and Citrobacter produces neonatal meningitis with a high incidence of brain abscess formation. To be honest, I've never seen this Citrobacter abscess in all my career, and it is not even discussed in like specialty ward, but it is mentioned here. It means that you should know this because sometimes an examiner might find this sentence and like want to bother you. With current management, the mortality rate of bacterial meningitis in children remains significant, up to 15%, depending on the organism and the study. 15% is really high today. Morbidity and mortality are higher with the Streptococcus pneumonia, unfortunately. It is the most prevalent, and we have most of our morbidity and mortality with this organism. Of survivors, up to 30% have sequelae, including deafness, seizures, blindness, paresis, ataxia, or hydrocephalus. All patients with meningitis should have a hearing evaluation before discharge and at follow-up. This is important. All meningitis cases should have a hearing evaluation before discharge and at follow-up. Depends on what you'll get at the first one. Poor prognosis is associated with, I know that examiners also like these sentences as well. Poor prognosis is associated with young age, long duration of illness before effective antibiotic therapy. It's sad. As long as you miss the time, as long as you pose your patient to bad happenings, seizures, coma at presentation, but not seizure at presentation. Okay? Seizure overall, but coma at presentation. Shock, low or absent CSF white blood cell count in the presence of visible bacteria on CSF. What does it mean? It means that when you perform LP and you have prepared the smear, you are seeing, for example, gram-positive diplococci, which is Streptococcus pneumonia, but there isn't any PMN or lymphocyte there. It's another sign of this one, long duration of illness. As long as the bacteria invade the meninge, as much as the our white blood cells got stuck in a battle, and sometimes we miss all of them in CSF. And immunocompromised status, this is obvious. So poor prognosis, young age, because in younger age, the development of CNS is poor, so the complications of meningitis are more obvious. Long duration of illness, seizure, coma, shock, low or absent CSF white blood cell counts, and immunocompromised. We normally don't see relapse and recurrence in meningitis, but sometimes it happens. And it's, as we talked about it, it might be because of premeningeal foci or resistant organisms. This premeningeal foci is that we talked about it, the abscess or the, what was it, effusion that might be there. So you'll see that your patient is going to be better, but all of a sudden after 3 days, after 4 days, it's getting worse. The symptoms are getting worse. And recurrence, this is interesting. Recurrence may indicate an underlying immunological or anatomical defect that predisposes the patient to meningitis. We had a case report of a 9-year-old child which had his 3rd episode of meningitis, all of it meningococcal meningococcus. And it's really rare because meningitis is among the infection that most patients just experience once. And in this young child, it was his 3rd time of infection. And we found that his sibling died out of meningitis in younger age. And it caused us to think about immunological defect. For all immunological tests comes normal. So we performed CT scan. At the beginning, CT scan reported normal, but when an expert radiologist reported, we found that there is a tiny defect in base skull, which prone this patient to meningitis. And this patient referred to neurosurgeon and really survived and then after. And about prevention. We know that there are immunization vaccines against H. influenza, Streptococcus pneumonia, and Neisseria meningitis. Unfortunately, we just have H. influenza in our routine, in Iranian routine vaccination schedule. Streptococcus pneumonia is not still there, and Neisseria meningitis. Nelson is about United States, so you might have different information of what you have in your countries and in Iran. So I'm not going to tell you in detail about this, but chemoprophylaxis is important. What does it mean, chemoprophylaxis? It means that when a child, you diagnose a child with meningitis, you should prescribe medication for other family members or dormitory classmates, or for the medical staff who were in close contact with the patient. Okay, and what are these? They have a wide range, but one of the most important one is rifampin. So you might be asked about the rifampin. Let's see what are the others. Ciprofloxacin is the other one, azithromycin, ceftriaxone, and it is not there isn't here anything about for whom you should start chemoprophylaxis. I'm not going through that. And for invasive H. influenza type B, prophylaxis consists of rifampin. You can omit this invasive. for every kind of H influenza type B. Prophylaxis consists of rifampin. And yes, just it. It's a very long story in Nelson, but it's summarized here. If we do have time, we can talk about encephalitis, but as it's not as important as meningitis, you tell me if you want to continue or we can finish our session. Let me see you all. Okay. It seems that these thanks at the end means goodbye. Am I right? Okay, no comment.
Yeah, thank you so much, Professor. It was really an amazing lesson. We learned a lot.
Thank you. That's nice to hear.
Thank you so much.
Okay. Have a good evening. And
Can we
mhm.
can we have that file, the Word file, which you have a summary of?
Oh yeah, for sure. I
yeah,
send it to Ranga.
Thank you so much. That one is very important for us.
Mhm.
Thank you.
Okay. Thank you. Have a nice evening. Bye-bye.
Bye bye.